Well, welcome everyone to the EKG case for the week of April 1st, 2012. Before we get going with this case, please make sure that you review last week's case where we talked about Wellens sign or Wellens syndrome because we're going to continue on with that theme. And we're going to start out with this case of a 31-year-old man who presented with atypical chest pain. Now, for those people that are familiar with Wellens, hopefully you're looking at the T waves in the mid-precordial leads here, and perhaps you're just a little bit scared of what they look like. These are awful looking T waves, and most people would look at this and say that this patient has Wellens sign, therefore has proximal LAD disease. It turns out, however, that this is not Wellens sign. In fact, what I'm doing is I'm throwing a curveball at you because this week what we're going to do is we're going to talk about a mimic of Wellens. This is actually a normal variant that if you get a lot of EKGs on young men, you're going to see this and you may be misled into calling this Wellens. And if you overcall Wellens, the problem is you send him to the cardiologist. They take him oftentimes to the cath lab because the EKG machine is going to read this as highly concerning for ischemia as well. And they end up with clean coronaries. The result is a lot of cardiologists stop believing that Wellens actually exists. And I'm convinced that a big reason why a lot of cardiologists don't believe in Wellens is because things like this end up going to the cath lab as so-called Wellens and having clean coronaries, so they think it doesn't exist. This is a normal variant, folks. This is a normal variant. You'll see ST segment elevation in the mid-precordial leads. You'll also see that biphasic T-wave pattern that we talked about last week. And in fact, let me blow this up for you. There's a couple of things that distinguish this from true Wellens. First of all, despite the presence of the ST segment elevation, first of all, these are always males, okay? So if you ever see biphasic T waves in women, then you've got to really worry about it. The other thing is that you'll notice that there's extremely high voltage. Let me go back a little bit. In all of these leads, you see really, really high voltage. When you see high voltage or large amplitude QRS complexes with, the other thing you look for is, get rid of that. The other thing that you'll look for is this little fishhook type of pattern, which is present not necessarily in all of the precordial leads, but in some of the precordial leads. This is the normal variant pattern that oftentimes occurs in young, fairly healthy men, and it tends to be misdiagnosed as Wellens sign. Okay, so this is true Wellens. I showed this to you last week. Let me just point out a couple of things. Number one, on this true Wellens case, there are no leads that show high voltage. These are normal size QRS complexes. So the first thing to remember is you can't call something Wellens when there's large amplitude QRS complexes. The other thing that you'll notice, let me go back for just a moment here. The other thing that you'll notice with this morphology is that we already mentioned that there's a little fishhook, but right after the fishhook, you get a concave upwards ST segment, and then it drops very rapidly like a roller coaster into the T wave. That's very characteristic of this normal variant pattern. When you look at the true Wellens, first of all, you'll notice that there's no fishhook in any of those mid-precordial leads. You also don't see a concave upwards ST segment elevation before the drop. It's just oblique, or sometimes it might be even a little convex upwards before the drop. That's what true Wellens ought to do. So again, no high voltage and no fishhook in true Wellens. This has actually been reported in the literature in several publications. I first learned about this in 2003. This is a New England Journal of Medicine article by Wang and colleagues, ST segment elevation in conditions other than acute myocardial infarction. And one of the particular patterns that they talked about, as shown here in tracing 3, if we blow that up, is exactly what we're talking about. This is a very common normal variant which tends to occur in young men, especially African American men. And again, what you'll notice, there's ST segment elevation, there's high voltage in a lot of these leads, and then you also see that little fishhook pattern just after the QRS complex. Fishhook is a term that Marriott used, and so I use the term fishhook. That little notch, it doesn't have to be in all of the leads, but in some of the leads you get that little notch, and then, like we talked about just a moment ago, right after the fishhook you get a concave upwards ST elevation, and then it drops down into that inverted T wave there. It looks for all the world like wellens, except you have to remember there's high voltage, there's a fishhook, and it's concave upwards before the drop. Let's look at a handful more examples just to really hammer home this normal variant finding. Here's another one. Notice high voltage in a bunch of leads. What else do you notice? There's that fishhook pattern. It doesn't have to be a fishhook in all of the leads, but in some of the leads you see that fishhook pattern, and then again concave upwards and then the steep drop. That's a normal variant pattern. Here's another example. Some pretty scary looking EKG leads up here, but in this particular case, take a look at lead V3, right? When you look at V3, you see that fishhook type of pattern, and then it's concave upwards before the steep drop. There's a fishhook in lead V4 also. Let me show you another normal variant patient. Again, high voltage in a lot of leads, and there's that fishhook pattern in this particular case. It's primarily just there in V4, maybe just a hint of it in V5, and then in that V4 concave upwards and then steep drop. That's not wellens, okay? Wellens should not be diagnosed in the presence of high voltage or that fishhook type of pattern. Here's another example. This is a really scary looking 12-lead EKG. V2 would have me worried. V3 would have me worried, but you keep marching through here, and what you notice up in V4, you get that fishhook type of pattern. It's concave upwards and then the steep downward drop. Again, the fishhook and the concave upward pattern, those don't have to be present in all of the leads, but if you see it in one or two leads, it's a clue that you're looking at the normal variant pattern and not the true Wellens sign. Let me show you yet another example. Once again, in this particular case, you don't see the fishhook in all of the leads, but you see maybe just a little hint of the fishhook pattern in V3 and a hint of the fishhook pattern in V4, and then it's concave upwards and then steep drop. Concave upwards and then steep drop. Let me show you yet another example. This was sent by one of our residents who was rotating through a pediatric hospital, Katie Bogger. This was a 18-year-old male who presented to the emergency department complaining of chest pain after using some amphetamines. Notice the EKG machine always reads these as acute STEMI because the EKG machine doesn't know about this normal variant. So you're going to have the EKG machine telling you that you're looking at a STEMI. And when you look carefully, first of all, you notice high voltage in a bunch of these leads. Okay, there's your high voltage. And then you look in at least one or two leads, you notice that fishhook pattern in V4, V5, and it's concave upwards and then steep drop. Concave upwards and then steep drop. That's not Wellens. That's the normal variant pattern, very common in young men, especially African American men, and especially in athletic men. It's a normal variant pattern. Again, if we just blow this up, I think you get a sense that the fishhook pattern really is fairly obvious, not in all of the leads, but at least in some of the leads. In this particular case, what they did was they admitted the patient to the hospital. They ruled him out. Fortunately, they didn't take him to cath, but they ended up ruling him out, and they realized that this was just a normal variant pattern. Okay, so this is a common mimic that you're going to see if you get EKGs on young men. Young can be up to 40, 45 years old. You can see this pattern. It tends to be most common in African American men. One of the articles I saw actually reported that it tends to be most common in African Americans of Caribbean descent. I don't know whether it's limited to that particular ethnic group. I've seen it in a lot of other men as well. It's extremely uncommon. If ever it occurs. I've never seen it occur in women. So don't even think about this in women. Young men, athletic men, African American men, the fishhook pattern with the concave upwards and then steep drop, and there's high voltage. If you see that, you're not looking at Wellens. Chances are you're looking at a normal variant pattern. Now, is it possible these patients have underlying cardiac disease? Sure. It's possible that a patient with a normal EKG has underlying cardiac disease. But the point that I'm trying to make is when you see this normal variant pattern, you can't call it Wellens, and your machine's going to call it a STEMI, but it's not actually a STEMI, it's just a normal variant. My recommendation is when your machine's calling it a STEMI, but you know better, get on the phone with your cardiologist and get them to take a look at it also. Don't try to be a hero and just ignore the cardiologist. Get the cardiologist on the phone, tell them, You think it's a normal variant pattern. You're worried because of the machines calling it STEMI. You want them to take a look at it also. One of two things will end up happening in that scenario. Either your cardiologist will know about this and they'll say, you know what, you're right. This is just a normal variant pattern. We're not going to do anything. We're just going to watch your patient. Or if your cardiologist doesn't know about this, your cardiologist may say, oh, I've got to take this patient to the cath lab. And then they're going to take the patient to the cath lab. The patient's going to have clean coronaries. And then they're going to respect you for knowing something that they didn't. They won't tell you that, but they will certainly understand that you know more about electrocardiography than they thought. Anyway, one final slide that I'm going to give you. There's more information about this on the advanced EKG course that we did for eMed Home. So if you want to learn more about some of the mimics here, just take a look at emedhome.com. There's a 6-hour advanced EKG course, 9 hours of CME from ACEP, and a certificate of completion from ACEP if you take a look at that and you go through the full course. I don't get any money for promoting this, by the way, but I think it's a pretty good course, and so check it out. And well, that's it. Next week, actually, we're going to talk about one other mimic of Wellens, and I'm not going to give it away just yet, but next week we'll talk about this other mimic of Wellens that I think everybody really, really needs to know. So until next week, take care.